the reason we're seeing polio rise again is probably related to a worldwide issue, and it has to do with the types of vaccines and vaccine penetration. So the types of vaccines we have are twofold. One is called IPV, which is an inactivated polio vaccine, and that's the only one available in the United States since the year 2000. So inactivated polio vaccine is what's recommended for children universally, and because it's inactivated, it cannot sort of mutate or turn into a vaccine-derived version of it. The other vaccine which is available is called OPV, or oral polio vaccine, which is a sort of a live vaccine. So in certain places, if your vaccine penetration is not high enough, meaning at a population level, and you are exposed to somebody that has just had oral polio vaccine, you can give it a chance to mutate in somebody's GI tract, for example, stomach or intestine. And then if an unvaccinated person comes into contact with that, potentially they could get a vaccine-derived polio infection. And that's what happened in this patient in Rockland County. So I don't know if that fully makes sense, but it has to do with if, for example, the vaccination rate in a place like Rockland County was close to 100%, which it's clearly not for children, then even if you were exposed to somebody that potentially shedding the oral polio vaccine in their stool, or you are unlikely to get any serious complication from polio. You may get the infection, it may cause nothing for you. But when the vaccine rates are low, and some estimates in the sort of children under 2 in parts of New York State, you're talking about vaccine rates that are under 40% by age 2, you're now sort of at risk of potentially having a lot of people being exposed to oral polio vaccine related to travel, and then potentially having that cause an infection in those unvaccinated people, or even children or adults for that matter.